start the recording. Good. All right. So good afternoon, everybody, and good morning to Professor Yogesh Lankadeva. It's a real pleasure to be here and to start this webinar, which is, as you know, a webinar that we organize from different residency schools in Italy. So Milano Statale, Milano Bicocca, San Raffaele, and Torino. So welcome to everybody. And thank you really very much for being here. It means really a lot for us, also because, as we just discussed, it's 2 a.m. in the morning. I know you don't sleep that much, but still, it's really very impressive that you accepted to join us. So thank you very much. So a brief introduction. Professor Yogesh Lankadeva is head of the Stroke and Critical Care Research at the Florey Institute of Neuroscience and Mental Health in Victoria, Australia, and also head of the Translational Cardiovascular and Renal Research Group at the same institute. So he performs really amazing research, translational research, going from animal models of acute and critical care, critical illness, to clinical studies and clinical trials. He focuses on different aspects of sepsis, of cardiac surgery, of brain and kidney injury. And we are really, really eager to hear your talk and really looking forward to it. So thank you so much. The stage is yours if you want to share the screen. We have about 50 minutes of presentation. The attendees can ask questions through the chat box, so please do so. And we will collect all the questions, and Dr. Silvia Coppola will summarize them at the end of the presentation to Professor Yogesh Lankadeva. So thank you very much.
Great. Thank you, Thomas. Can you hear me? Okay.
Yes, we can hear you. Very
Great.
good.
And
we see the slides.
Okay, great. Look, I'd like to begin by really thanking you, Thomas, for the invitation, and also Professor Giovanni Landoni for inviting me as well, who I met in USA last year at a Sunnable Symposium. It's a real pleasure to be here presenting our work from Australia. And I would like to take you on a journey of, I guess this is sort of like bi-directional research where we try to understand the disease pathophysiology of sepsis and cardiac surgery, and then try to forward translate what we find in terms of diagnostics and therapeutics. And then if we do see something not going so well in a clinical trial, we bring it back, optimize again in our research group in the laboratory, and then send it back to clinic. That's really the ethos of what we've tried to create. So I have had the pleasure of being the head of the stroke and critical care research priority area at the Florey, but mainly I'm focused on the critical care research, and I do this in close conjunction with the Department of Critical Care at University of Melbourne. The primary basis for this work is to co-design clinically relevant sheep models with practicing clinicians to minimize deviation from clinical practice. No animal model is going to be perfect. We all know this, but our goal is to get it as close as possible. So the knowledge we get from the animal model can be, related to humans, and then also the new devices or new drugs we develop can be seamlessly and safely translated to humans. And we use sheep as a model for this because they are a docile, animal, and you can actually do chronic recordings in both the anesthetized and non-anesthetized sheep over extended periods of time. And through aseptic surgical techniques, we can really instrument multiple organs in the sheep model and study them in the conscious and anesthetized state. We can instrument the brain to measure EEG directly on the dura. We can put probes to measure cerebral tissue perfusion oxygenation. Recently, we even started putting lateral ventricular guide tubes to measure ICP and also collect CSF to see how much drugs can cross over and the effects of that on ICP and CPP. We can basically, catheterize the cardiovascular system very well. We can instrument the kidneys to look at the macro and microcirculation. We can instrument the heart to look at, cardiac output in real time. We can put a catheter in the left atrium to measure left atrial pressure. So this is really a full suite of multi-organ physiology in health and disease. And really the two main areas I will cover for my talk today is our bidirectional research programs in sepsis and cardiopulmonary bypass. But we also have developed models of continuous renal replacement therapy, and also models of heart failure with reduced ejection fraction, and then going through cardiopulmonary bypass as of recently. So I probably don't have to tell this audience how much of a problem sepsis is. It's a leading cause of death in intensive care units. And a large part of my career when I first began with Professor Ronaldo Bolomo, who I'm sure you know, and he's been a great mentor and a working father for me, who we unfortunately lost last year. But in a lot of ways, septic acute kidney injury is where I started my career. So I'm going to focus my talk a lot on this, and then an extension of this is where it kind of ended up later on. So really, this is the leading cause of acute kidney injury currently. Up to 50% of patients develop acute kidney injury, and 1/3 of these patients do not leave the hospital alive. And the concerning fact now is that the patients that survive acute kidney injury commonly transition to chronic kidney disease in later life. So if you look at the standard of care treatments at the moment, I would say none of these are really targeted towards the pathophysiology of septic acute kidney injury, largely because the pathophysiology is also very complex and heterogeneous. However, the development of new effective therapies is a global healthcare priority for this. So because we can't study pathophysiology in mechanistic detail in critical ill humans, this is why we need clinically relevant animal models. And we believe we do have one of these clinically relevant animal models at the Florey, where this work really began with Professor Clive May and Professor Ronaldo Bolomo and Christopher Langenberg, who was a nephrologist in 2006, where they developed this sheep model where they isolated a gram-negative bacterial strain that commonly causes sepsis in the community in Australia, and then they gave it intravenously into sheep over 24 to 48 hours. And during this time frame, and this is in non-anesthetized sheep, and during the 48-hour time period, the sheep develop a hyperdynamic sepsis profile that's characterized by an increase in cardiac output. But this increase in cardiac output is really offset by even bigger peripheral vasodilatation, leading to hypotension. The sheep also develop tachycardia, tachypnea, hyperlactatemia, and over a 24 to 48-hour period, they develop acute kidney injury stage 1 to 2, according to KDIGO criteria. But the fascinating thing they found in 2006, when they can directly measure renal blood flow by putting a flow probe on the renal artery, continuously over 48 hours of septic AKI development, is that total kidney blood flow increases. And then, however, despite an increase in total kidney blood flow, there is a progressive reduction in glomerular filtration rate, which suggests that global renal ischemia is not a prerequisite for the development of acute kidney injury. In fact, acute kidney injury can still develop due to even in the face of renal hyperemia. So this is when I came in actually to the Florey around 2013, and I had a big focus on the microcirculation. So really, my question was: is the macrocirculation uncoupled from the microcirculation in sepsis? And there's quite a bit of literature on this non-invasively by looking at the sublingual circulation in patients with septic shock, showing this heterogeneity of perfusion in the tongue, where certain regions of the tongue can be overperfused and over-oxygenated at the expense of other regions of the tongue experiences selective ischemia and hypoxia. So the question for us was, does this concept of redistribution of blood flow and oxygenation happen in internal vital organs like the kidney? To do this, we had to kind of develop this technique where we not only instrument the macrocirculation with renal probes and then renal venous catheters, but we developed these custom-built fiber optic probes that can be inserted into the renal cortex and medulla. So it can also measure renal microcirculatory perfusion and oxygenation during the development of septic AKI over a period of 32 hours. And what we showed was that with an increase in total kidney blood flow, the renal cortical tissue perfusion and oxygenation tended to remain the same or even elevated, but there was selective reductions in renal medullary tissue perfusion and oxygenation by 24 hours that kind of kept on going for about 32 hours. And then and the great thing about this model is you can experimentally track the infection and the development of acute kidney injury. And acute kidney injury characterized by increases in plasma creatinine, and oliguria dwells by 24 hours, but we also saw this progressive reduction in medullary tissue perfusion oxygenation started happening from the first hour of infection all the way till 24 hours. So we really believe that this medullary hypoxia is probably a initiating factor in the, it's kind of like kickstarting the acute kidney injury cascade. And then a large part of my work was a labor of love after that, trying to reverse renal medullary tissue ischemia and hypoxia in established AKI. And we went down the whole pathway of looking at fluids like balanced crystalloids, unbalanced crystalloids, like vasopressors like noradrenaline, angiotensin, vasopressin, sedatives like dexmedetomidine, clonidine, diuretics, furosemide, azoxystrobin, amiloride, antioxidants like Tempol, and really it was really disheartening, to be honest, because we were looking at multiple organ physiology and none of these drugs really did anything to reverse acute kidney injury. If anything, every improvement in renal function was transitory, and then it kind of went back to really back to the bad states in sepsis. And in some cases, some drugs cause side effects in organs. Like one drug that's good for the brain might not be good for the kidney. If it's good for the kidney, it's not good for the brain. This is why sepsis is very complicated. Very few drugs work for multiple organs. And one thing became obvious to me. It's really that a drug with a single mode of action was probably not going to be the silver bullet for such a complex pathophysiological condition like sepsis. This is when I became very interested in the active pharmaceutical ingredient of vitamin C, which is ascorbate, because ascorbate has multimodal effects, and putatively it could be beneficial for sepsis. And there was a big interest in this starting from 2017 onwards, even in the clinical field. And really, it's got antioxidant effects. It's supposed to have anti-inflammatory effects, anticoagulant effects. It's supposed to be a co-factor for the endogenous production of vasopressors like endogenous norepinephrine and vasopressin. It's supposed to be innate immune cell stimulant. It's supposed to improve nitric oxide bioavailability. So theoretically, this could be a potential treatment for sepsis. And there's also a rationale for vitamin C infusions in sepsis, because patients with sepsis has been reported to have abnormally low plasma ascorbate concentrations, almost to the levels you find in scurvy. But really, if you were to understand the biochemistry of this molecule and the rationale, you really need to get this inside the cells. And that's what's really hard, because you need to give very large doses to really circumvent the traditional sodium-dependent ascorbate transporters and really pass it down the GLUT transporters into the cells, where it could really convey its intracellular benefits. So we really wanted to find out how large can we go with vitamin C, and we've done quite a bit of scoping reviews at the time to find out that up to 200 grams of vitamin C has been administered to patients with cancer and burns victims, really without inducing any adverse incidents. This is a lot. This cannot be given enterally. It has to be given intravenously. This is about 2,500 oranges worth of ascorbate. But then you cannot give it in its traditional form for sepsis. It didn't make sense to us. And every other randomized clinical trial to date has used vitamin C in the form of ascorbic acid. And you are probably aware of the LAVIT trial, the REMAC-CAP trials, which use ascorbic acid in the form of, vitamin C in the form of ascorbic acid. The problem with this is it has a very low pH. So it's around that 5.4 to 5.6 mark, which might be okay for normal patients, but in conditions where there's incipient metabolic acidosis like sepsis, this level of infusion of titratable acidic solutions intravenously could be harmful. And in fact, there has been harm signals reported. We were trying a different approach at the time. We thought we should develop a pH balanced formulation of sodium of vitamin C. So we were really developing a new formulation that was sodium ascorbate, that you can appreciate here has a pH of about 7.2. It's temperature dependent, really. So really, you gotta watch out for that as well. But really, at a normal body temperature of 37, it's about 7, and at a febrile temperature, it's about 7.2. So we thought this is probably a better formulation to move forward with, where we can administer larger doses without exacerbating the incipient metabolic acidosis. And then we went back to our sheep model and really trialed this out. So these sheep were left with untreated sepsis for 23 hours. Then they received the standard fluid resuscitation with balanced crystalloids. And then if blood pressure kept dropping, we started noradrenaline treatment with and without sodium ascorbate. And we found something remarkable. What we found was, both groups, the weaker group in red, the ascorbic group, obviously before treatment, had low blood pressure, fluid resuscitation, transitorily improved blood pressure, but then you needed escalating dose of norepinephrine to maintain target blood pressure in the weaker group. But in the sodium ascorbate treatment group, we can progressively wean the animals completely off norepinephrine, and they can still maintain the target blood pressure. Then if you look at the renal medullary microcirculation, again, as I mentioned, there's renal medullary ischemia and hypoxia, and infusing high dose of norepinephrine makes this worse. And we have seen this time and time again. Norepinephrine in the settings of medullary ischemia and hypoxia in both sepsis and cardiopulmonary bypass is not good for the kidneys. And again, really, sodium ascorbate completely restored renal medullary tissue perfusion and oxygenation to pre-morbid baseline levels. And for the first time since the development of this model in 20 years, which even preceded my time, we saw complete reversal of septic AKI. There was profound improvements in urinary output, and there was normalization of plasma creatinine and sustained increases in creatinine clearance. One of the other perceived harm signals of giving vitamin C, at least in the form of ascorbic acid, is that high doses were thought to cause oxalate nephropathy. So this is something we were very worried about. So we did extensive renal histopathological investigation in the renal cortex and the renal cortical medullary junction and the renal medulla to really overrule that at least megadose sodium ascorbate did not induce oxalate nephropathy in the kidney. There were no bifringent oxalate crystals. There were, and this model of AKI in sheep is not really characterized by ATN acute tubular necrosis or even extensive tubular cell apoptosis. So that wasn't really different between the groups, but there was no oxalate nephropathy. So we were confident that this is safe. And then we were presented with this patient, which is a very interesting case report. It was a 40-year-old man who contracted COVID-19 and then developed E. coli superinfection on top, and then was admitted to one of our ICUs in Australia called Austin Health, developed septic shock, and then on intensive care day 3, stopped responding to standard of care treatments. And we received consent from his wife to administer megadose sodium ascorbate on compassionate use grounds to this patient. And some of the signals we got was very similar to what we saw in sheep. This is a 7-hour infusion with a bolus and a continuous infusion. And this patient was weaned off noradrenaline immediately following the bolus of sodium ascorbate. Blood pressure started improving. The patient's level of tachycardia started reducing. The patient's requirements for supplemental oxygen started going down, but arterial PO2 levels started going up. Serum creatinine levels started coming down. This patient was extremely oligouric, producing under 10 mils per hour of urine for the last 3 days. Now started producing over 400 mils per hour of urine. This patient was extubated 12 days after treatment, followed by complete hospital discharge at 22 days after treatment. So this was a win for us, but we still needed to look at the other organs as well. So then we started looking at the brain in sepsis and really started to understand the pathophysiology in the brain as well. So we started extending our fiber optic technology to stereostatic surgery to implant these in the frontal cortex. That's the area of the brain that's involved in executive functioning and cognition. So we thought we'll start there. And what we saw was that sepsis was associated with frontocortical tissue ischemia and hypoxia in the cerebral cortical tissue. And while this ischemia and hypoxia persisted in the vehicle treatment group, sodium ascorbate improved perfusion and oxygenation to the frontal cortex. And quite a cool finding is that this area of the brain gets very hot. So there was quite a significant hypothermic response in the frontal cortical tissue, and sodium ascorbate seems to normalize brain temperature. And most remarkably, because we're doing this in the non-anesthetized sheep, all these findings aside, there was a remarkable behavioral change that happens when the brain starts becoming better. The sheep are lying down, malaise, unresponsive to external stimuli, not eating or drinking. But by about 4 hours into treatment, they start looking up, They start looking around, and then by the end, they're literally standing up and eating and drinking, which is really, really different from what we see with sheep at 31 hours of sepsis when they're quite critically ill, like a very sick human. So it was very hard to blind this experiment in the at least in the laboratory for this reason. Then we started thinking, okay, well, we're giving a high sodium load. Is it the sodium that is causing these benefits? Are we saturating the renal transporters and inducing diuresis and natriuresis? Are we making our patients dry? I mean, are we dragging the extravascular fluids into the intravascular component? Is that why blood pressure is becoming better? So we then started looking at equimolar intravenous sodium infusions in the form of sodium bicarbonate. Not to, at a level that we didn't induce metabolic alkalosis, but this was a good level. And what we saw was that it wasn't the sodium. The animals that received equimolar sodium still required norepinephrine to maintain blood pressure, whereas sodium ascorbate, you can wean them off. The brain remained hypoxic. The brain remained hypothermic. And if anything, we had to stop this study prematurely because that level of sodium by itself started inducing seizures in the animals. So this is a very difficult experiment, but it gave us confidence that it wasn't the sodium load that was producing the benefits that we were seeing with the sodium ascorbate. Then, we could also address the LOVEIT trial. I mean, how different is ascorbic acid from sodium ascorbate? Like, is null vitamin C the same? We don't think it is. And we started looking at the LOVEIT trial product. We actually imported that from America and then started comparing this head-to-head with sodium ascorbate. And this is unpublished data. We're about to submit this to a critical care journal soon. And the animals that received ascorbic acid, the LOVEIT trial product, required more and more norepinephrine to maintain their target blood pressure. The medulla state, there was exacerbation of hypoxia in the medulla. Lactate levels started staying up. And then if you actually look at internal vital organs, it was quite concerning to see what's happening inside the body. Physiologically, this tracks a normal vehicle treatment group, but internal vital organs were not doing too well. And when we looked at the histopathology, the kidneys really took a hit in the animals that received ascorbic acid. Now there was ATN, there was acute tubular necrosis, there's casts in the kidneys. And now that putative arm signal everyone thought about started appearing, oxalate nephropathy in the form of bifringent oxalate crystals and calcium crystals started forming across the glomerulus, and this in the renal cortex, and then also quite significant nephropathy across the renal medullary peritubular capillaries as well. So we do not believe all vitamin C is created equal, at least for sepsis. So that's what we have found so far. But what we have done since then is really to do a double-blind, randomized, placebo-controlled trial in patients with septic shock. Now, we couldn't go as high as we wanted to, but we wanted to try 60 grams of sodium ascorbate, which is still a big step up from what they have used in previous clinical trials, or patients randomized to fluid-matched dextrose. And this was in patients with septic shock that was diagnosed according to the current sepsis criteria. The primary outcome of this trial was, of course, safety and feasibility. And secondary outcomes was cumulative increase in urinary output, reductions in vasopressor requirements, and SOFA scores following study drug design. And what we saw was that this treatment was safe. It was feasible, at least with 60 grams. But and we achieved some physiological signals of benefit where there were significant improvements in cumulative urinary output within 24 hours of infusing sodium ascorbate in patients with septic shock. And these patients required less norepinephrine to attain target blood pressure of about 65 millimeters of mercury. And there was more rapid reductions in SOFA scores. This was a statistically fragile signal, nevertheless a signal with a suboptimal dose of sodium ascorbate. However, one of the risks we had, even in the animal model, was that because of the sodium load, there was a hyponatremic response. And this is what we were concerned about. That's why we chose 60 grams. So what we saw here was even with 60 grams, there were significant elevations in arterial blood sodium levels. So this was a good signal that also translated from the sheep. So these are the clinical highlights of this study. And one of the risk signals we really wanted to mitigate was this increase in blood sodium levels in the patients, because we wanted to go higher in dosage. So this is the best thing about bidirectional research programs that I mentioned before. When you see this risk signal, after forward translating it, we can reverse translate it to the sheep model again, because this was too salty, this formulation. And then we have modified the formulation now to really circumvent this hypernatremic problem. So we can administer larger dose of sodium ascorbate guided by minimum therapeutic dose finding studies in our sheep model to improve its safety and efficacy profile. So this is a recent article that just came out in Critical Care, where we did an extensive preclinical randomized controlled dose finding study to determine the minimum therapeutic dosage of sodium ascorbate required to reverse cerebrovascular, cardiovascular, and renovascular dysfunction in sheep with gram-negative sepsis. And we need 3 grams per kilogram of sodium ascorbate to achieve the optimal plasma concentration of sodium ascorbate, which is 10 millimolar per liter, to really start having these multiple organ benefits. So we have trialed this in a patient as well. You might think we're crazy in Australia, but we have given 240 grams of sodium ascorbate in this modified formulation to a patient again. So this patient was a patient with infected prostatic hip with MRSA, went to surgery to clear the pocket of infection, and then had a gut perforation and developed was profoundly shocked, was on maximum clinical support with norepinephrine and vasopressin. But then we started the sodium ascorbate at 240 grams. And again, this patient was weaned very rapidly from both drugs within a 24-hour period, followed by discharge from ICU at day 7, followed by complete hospital discharge at day 21. So then we were very fortunate to receive a $4.9 million Australian federal government grant to really translate this forward to multi-center clinical trials across every state and territory of Australia. So we've just started recruiting patients for the phase 1B multi-center trial, where we're going to that really high dose of sodium ascorbate, and we are recruiting 50 patients with septic shock across 11 hospital sites in 4 states and territories in Australia. Sorry, 5 states and territories in Australia. And this is a wonderful program. It's been a real honor to lead this program from the vanguard. It brings together great scientists from a suite of medical research institutes that allowed us to understand the mechanism of action, and also clinicians from 25 sites across Australia, and also people with direct lived experience of sepsis, survivors of sepsis. The community is also starting to get behind us, and we have annual retreats. This is the Megascores group. I like to share this because this is one of the last, this is the last retreat that Professor Balomo was with us. So he was very proud to see this program really take off. And we really missed him at the last year's retreat, which was in Adelaide. Okay, so that's sepsis. I'm going to take a little bit of a side movement into cardiac surgery. Cardiac surgery requiring cardiopulmonary bypass, and talk about why we are interested in this pathophysiology as well. Sepsis might be the most leading cause of acute kidney injury, but cardiopulmonary bypass is the second leading cause of acute kidney injury. That's what motivated me to start my research there. But we are really interested in not just the kidney now, but also the brain, because acute brain injury characterized by delirium and cognitive dysfunction can occur in about 50% of the patients. And these patients who survive do transition to persisting cognitive dysfunction and develop dementia within 7 years of the operation. And as I mentioned, up to 30% of the patients can develop acute kidney injury, and these patients also transition to chronic kidney disease in later life. And as I mentioned, we have very unique surgical techniques from the sepsis field that we can translate to the cardiac surgery. So we can pre-instrument the sheep with probes in their brain to measure the frontal cortical microcirculation in terms of perfusion oxygenation. We can pre-instrument the heart to look at real-time cardiac output. We can put catheters in the left atrium to look at left atrial pressure, and then we can pre-instrument the kidneys to look at both the macro and micro circulation. Now we are in a position to look at brain, heart, kidney health before cardiopulmonary bypass in the non-anesthetic state, take them through cardiopulmonary bypass, and then take them out to the recovery period with continuous measurement of brain, heart, and kidney health. And we co-designed this protocol with our clinical colleagues. There's a conscious baseline period, 30 minutes, where we measure things under general anesthesia, and then following aortic cross clamp, we do 2 hours of mildly hypothermic bypass, and then there's an off bypass period, then there's a transition from GA to sedation, and then we start monitoring things in the post-operative environment for 48 hours, which is the clinical window usually for brain and kidney injury development. the perfusion conditions that we are using. We are trying to minimize deviation from clinical practice. So these are some of the parameters that we use. And what we found was that renal medullary tissue oxygenation or reductions in renal medullary tissue oxygenation seems to be a common pathophysiological feature in also cardiopulmonary bypass. So even during cardiopulmonary bypass, there's significant reduction in oxygenation to the renal medulla. So, and then we looked at the postoperative environment, and this initiation of renal medullary hypoxia in the intraoperative period seems to now carry on to the postoperative environment. So this sheep, they're healthy sheep going through bypass, so the degree of AKI they develop is quite mild. We don't really get a creatinine signal, but we do hit the KDIGO criteria with just the urinary output signals. So there's about a 42% incidence of AKI if we just use urinary output as a measure. But renal medullary tissue hypoxia kind of carries on to the postoperative period. And the fascinating thing is the renal macrocirculation normalizes by 8 hours. So this intraoperative period, the hypoxia is driven by global renal ischemia and hypoxia. So this is different to sepsis during the operation, where sepsis, there's increase in renal blood flow, but then the medulla is compromised because the macrocirculation uncouples from the microcirculation. In the cardiopulmonary bypass, the macro and the microcirculation takes a hit during the surgery, and this medullary hypoxia is driven by global renal ischemia. But in the postoperative period, renal blood flow normalizes by about 4 to 8 hours. Then in the postoperative period, the microcirculation uncouples from the macrocirculation in sheep recovering from cardiopulmonary bypass. Then we took this sheep all the way up until 4 weeks after bypass, and what we showed was that the microcirculation was affected for the entire 4 weeks. There was ischemia and hypoxia in the renal medulla, but renal function really normalized. So even the oliguria went away after 48 hours. So there was completely normal renal function. But then when we did histopathology, the kidneys have taken a hit. Like there's a footprint, a structural footprint that's left in the kidneys in terms of there's peritubular infiltrate of leukocytes, there's interstitial fibrosis, there's cellular cast. This is a precursor for acute tubular necrosis. There was quite a bit of a structural footprint after cardiopulmonary bypass, which is also different from sepsis that didn't have that. So despite that, renal function was normal. So then we thought, okay, well, obviously we all know our current conventional diagnosis with creatinine and urinary output has limitations. So we thought, can we use the renal functional reserve to really unmask subclinical kidney injury? I'm sure this audience knows very well about the renal functional reserve because of the amazing work done by Professor Giovanni Landoni and his colleagues. But really, renal functional reserve is the maximum GFR minus resting GFR. And we can do this by the intravenous infusion of a clinically approved mixture of amino acids, synthamine that's produced by Baxter. And in healthy sheep, we have showed that we can successfully recruit the RFR, and it's actually good for the kidney. It actually improves the microcirculatory perfusion oxygenation in healthy sheep. But what happens to sheep after taking a hit with cardiopulmonary bypass was unclear. So we wanted to really examine the safety of the recruitment of RFR after CPB, but also to understand if RFR was a sensitive biomarker to detect subclinical kidney injury after bypass. And our hypothesis was that renal functional reserve would decrease after CPB. So this was our protocol. We did a baseline RFR measurement, then the animals went through bypass, and then they were recovered for 4 weeks. And then we did weekly RFR measurements with amino acid infusions all the way up until the 4-week time point. But okay, so despite the presence of renal structural injury, these sheep, at least the healthy sheep that has gone through bypass, seems to still be able to recruit the RFR quite successfully. So you can see the baseline recruitment of RFR, and at 1, 2, 3, 4 weeks after bypass, they can still recruit. However, as I mentioned, there is renal medullary hypoxia at 1, 2, 3, 4 weeks after bypass, and now amino acids did not improve this. So amino acids did not make it worse. Oh, well, actually at 2 weeks it did, but again, could be a type 2 error. But amino acids certainly did not improve renal medullary oxygenation after cardiopulmonary bypass, which differed from our studies in healthy sheep before bypass. So really, renal medullary hypoxia seems to be coming up as a common pathophysiological feature in both sepsis and cardiac surgery associated AKI. So we really wanted to understand whether we can develop a non-invasive biomarker to detect this in humans. So going back to the drawing board, this is a transverse section taken through the inner base of a rat medulla, where we have labeled the descending vasa recta, which is the primary blood supply to the medulla in red, and the collecting ducts in blue. And you might be able to appreciate that the renal medullary vasa recta in red is positioned close and symmetrically around the collecting ducts in blue. Due to this close anatomical relationship, we hypothesized that oxygen levels in the renal medulla would equilibrate with oxygen levels in the collecting ducts. Why do we care about this? We care about it because once it's the collecting ducts, the urine will come to the bladder. So we got together with our industry partners and developed a large area oxygen sensing probe, similar to what we found, did in the kidney, but this is a modified version that we can tunnel through a standard Foley bladder catheter. So it sits at the tip of the bladder catheter in direct contact with the patient's bladder urine. And we hypothesized that oxygen levels in the bladder urine would give us an indication of what's happening in the renal medulla. So we went into our experimentally tractable model of sepsis, where we know that acute kidney injury develops over 24 hours. As you can see in red, although acute kidney injury develops at 24 hours, there's progressive development of renal medullary hypoxia from the first hour all the way to 24 hours. And this profile was very closely reflected by bladder urinary oxygenation. And when we looked at it, there was a very strong and positive correlation between medullary tissue oxygenation and bladder urinary oxygenation during development of acute kidney injury. Then we translated this forward because in sepsis, it's very hard to do that because we don't know what the initiating insult is when acute kidney injury starts. But in cardiac surgery, we do, because it's elective surgery, the initiating insult is surgery. So we went into this population. This is a cohort of patients going through cabbage valve repair or replacement procedures at another one of our hospital sites at Monash Health in Victoria. And in this cohort, 26 patients developed acute kidney injury, 39 of them did not. But when we started measuring bladder urinary oxygenation from the insertion of the catheter in theater, both groups progressively reduced their bladder urinary oxygenation at each epoch of cardiac surgery. But the patients that developed acute kidney injury in the ICU had much larger reductions in bladder urinary oxygenation and spent more time in hypoxic regions than the patients that did not, suggesting that this could be a marker of early risk before acute kidney injury develops in patients going through cardiopulmonary bypass. Then using our sheep model, we're like, okay, well, hypoxia develops, what can we do to make it better? So we started doing various non-pharmacological interventions. We started looking at increasing pump flow, target pump flow. We started looking at increasing target mean arterial pressure. We started improving the target hemoglobin range. We started introducing a pulsatile flow. We started looking at hypothermia. None of these seems to really move the needle much on improving renal medullary oxygenation during cardiopulmonary bypass. But we got some positive signals with increasing pump flow and pressure, but we need to keep the surgeons happy by not increasing these things too much. So we thought, okay, what if we do a combination intervention where we increase target pump flow and blood pressure within clinically feasible ranges? And when we did that, that seems to produce a very good signal where if we did that combined intervention, we can achieve a 95% restoration in renal medullary tissue oxygenation that is primarily driven by improving renal blood flow and renal oxygen delivery to the kidneys. However, we should also understand the choice of vasopressor matters, and we have performed quite a bit of studies here looking at various vasopressors like norepinephrine, epinephrine, vasopressin, phenylephrine to look at which vasopressor probably doesn't exacerbate the microcirculation. And as with sepsis, we found that norepinephrine exacerbates the microcirculation even in cardiac. Having a bit of carry through. Sorry. So anyway, norepinephrine seems to be bad for the kidneys. Okay, so this is now again translated into cardiopulmonary bypass, and we've done imaging studies with microvascular imaging to look at norepinephrine and show that norepinephrine during cardiopulmonary bypass really does compromise the perfusion to the kidneys. We have also used bladder urinary oxygenations in patients that are recovering from cardiopulmonary bypass to show that norepinephrine does reduce bladder urinary oxygenation, which gives us an indication of what's happening in the renal medulla. Then we translated to another study where we looked at that increasing pump flow and pressure. This is a feasibility study. Our normal within patient crossover study. So our normal intervention was CPB flow rate of 2.4 liters per minute with a target blood pressure of 65. Then we targeted what we did in the sheep, which is target CPB flow rate of 3 with a target mean arterial pressure of 80 to show that this is feasible. We achieved that in the study. And then we used bladder urinary oxygenation to show that during the period of high flow and high pressure, bladder urinary oxygenation goes up. So bladder urinary oxygenation in this setting is not just a marker of risk of AKI, but it could also be used to guide clinical interventions like high pump flow and pressure. So that's the kidneys. Now a little bit about the brain. So we started looking at the brain tissue perfusion oxygenation in the sheep model. Unlike sepsis, at least under currently recommended clinical perfusion conditions, the brain perfusion oxygenation, at least the frontal cortex, does not seem to be affected during cardiopulmonary bypass. So there's no ischemia, there's no hypoxia in the brain. However, there is quite profound inflammatory reaction in the blood. So if we were to profile animals going through surgical trauma and general anesthesia and no bypass, and compared to animals that go through general anesthesia, surgical trauma, and CPB, you're looking at inflammatory markers in the blood. So really, CPB seems to exaggerate the peripheral cytokine response. So tumor necrosis factor alpha is a primary cytokine. It goes up and then comes down by 3 hours into surgery, but then it sets off this other secondary cytokine, interleukin-6. And this level of increase in peripheral cytokines can damage the blood-brain barrier and really cross over to the central nervous system. So we want to look at the effects of this level of peripheral inflammation that happens during CPB on the brain. Does it cause neuroinflammation? And the gold standard for looking at neuroinflammation is to look at this cell type in the brain called microglia. So they are the resident macrophages of the brain. In the resting state, they have this very ramified branch structure. They talk to other brain cells, but then when they are inflamed, they puff themselves up and they retract their branches and starts going through this morphological change from a resting microglia to a pro-inflammatory microglia. And when they get to this stage, this amoeboid shape, they can be quite harmful because they become phagocytotic and they can actually start eating brain cells. So it goes through this morphological change. So really, our question was very simple. Does cardiopulmonary bypass cause neuroinflammation more than what you would get in surgical trauma and general anesthesia? So we looked at these two groups. We looked at the frontal cortex, parietal cortex, temporal cortex, and occipital cortex in animals that went through just general anesthesia and surgical trauma, in a healthy group of sheep that underwent nothing, compared to animals that went through surgical trauma and cardiopulmonary bypass and GA. And what we found was that there was quite profound neuroinflammation in terms of microglial activation in the frontal cortex, parietal cortex, and the temporal cortex. The occipital cortex seems to be the only region of the brain that's protected from neuroinflammation. And the frontal cortex seems to be the most sensitive to neuroinflammation. The greatest degree of microglial activation was found in the frontal cortex, which makes sense because that's the area of the brain that's involved in executive functioning and cognition that manifests as delirium in the ICU. Again, we need to find ways to assess this in humans. We can't directly assess microglia in humans. We need to develop reliable blood-based biomarkers of neuroinflammation. Although this hasn't really progressed in critical care medicine or perioperative medicine, but blood-based biomarkers has gone quite far in the dementia field. And one of the markers that has proved to be a high fidelity biomarker of neurodegeneration is neurofilament light. This is released when brain cells, particularly axons and neurons, are injured. As I mentioned, it's been very well validated with MRI and PET studies in the dementia and Alzheimer's field. And you can measure this using the single molecular array Simoa technology, which I recently got at the Florey, which is great. So we started looking what happens to NFL during cardiopulmonary bypass in our sheep model. And NFL does not seem to elevate during surgery, but seems to take off in the postoperative environment at 12, 24, 36, and 48 hours. This is very preliminary work. Then we did an observational study in humans going through bypass to show that humans also have increases in NFL in the postoperative environment on days 2, 3, and 4 post-op. This is very early, so I'm not going to talk too much about this area. So really, summary here is acute brain injury in bypass seems to really be driven by neuroinflammation. even in the absence of cerebral tissue hypoxia. And acute kidney injury in this setting seems to be driven by a whole cascade of things like renal medullary tissue hypoxia, structural injury that's characterized by inflammation, and tubular injury. Really, we need a therapy to prevent both these things in cardiopulmonary bypass, but it's very optimistic because it's one of the few indications where we can initiate a therapy before injury happens. So with that in mind, we have received another $4.9 million grant from the Australian federal government to test sodium ascorbate during and after cardiopulmonary bypass surgery. And this again brings together a wonderful team of clinicians and scientists. But I want to also emphasize that the sepsis formulation of sodium ascorbate is not what we are using here. It didn't work. It didn't do. It's not appropriate to use that formulation. I can't talk too much about it because there's IP restrictions around it that refrains me from talking about it. But my advice is do not try to use the sepsis formulation in bypass because that will do harm. So with that, I would like to thank the mega heart team. So this is another great team of clinicians, scientists, people with direct experience and industry coming together to tackle this problem. And we're excited to see where this program really goes in the next 5 years. Finally, I would like to really thank my translational cardiovascular and renal research group at the Florey. So again, a very, very hard working group of scientists, research assistants, and PhD students. And of course, our funding bodies like the NHMRC, Heart Foundation, and the Medical Research Future Fund, without whose support, none of this work would be possible. So with that, I hope I'm on time. Thank you for your attention and happy to take any questions.
Okay, thank you for this excellent presentation that moves from experimental, animal, and clinical studies. There are some, can you hear me, Professor? Okay. There are some questions from the audience. We can start with a general question. Could you summarize what are the possible side effects of vitamin C and how this different between ascorbic acid and sodium ascorbate? This is the first question.
Great. Yep, of course. So I think the side effect that we saw with our first randomized RCT was the hyponatremia. So they did elevate sodium levels to about 155. Even in one patient, it went up to over the 160 millimole per liter threshold. But as I mentioned, I'm confident that might not be a problem in the next trial because we brought that formulation back and did quite extensive modifications to circumvent the hyponatremia signal. So that's what we have seen so far. And as I mentioned, the perceived risk was oxalate nephropathy as well, but we haven't seen that in the animal work. And we looked at oxalate nephropathy in the urine collected from the patients, and we haven't seen that in the urine either. So we're confident that's not an issue. But again, we need to do the randomized clinical trial that we are doing now because we are going on, very high, much higher doses than we used to with the first trial. So I think this new trial looking at safety and feasibility will be very telling. What's the difference between sodium ascorbate and ascorbic acid? Well, there's a very stark difference, I think. So the ascorbic acid formulation has a low pH, first of all. So it could increase the metabolic, exacerbate the incipient metabolic acidosis. But they've also added other things in there to stabilize this compound. So that they've added sodium EDTA, they've added sodium hydroxide. So there's a little bit of sodium in there, but adding artificial bases, what we have found in our biochemical work is that adding those things interferes with the body's ability to buffer towards alkalosis. So you need a lot more base to get towards alkalosis. So not only is it exacerbating the acidemia, but it's preventing the body mounting a response towards alkalosis. And also it's got EDTA that can chelate other ions like calcium, which will interfere with blood pressure control as well. So we are seeing quite profound differences between these two drugs in our ongoing work.
Okay. Another question. Can renal medullary tissue hypoxia be a sign of a renal cellular shutdown that finalistically aims at preserve renal function during sepsis?
I got the first part of the question. What was the second part? So I answered the cellular part. What's the second?
Can renal medullary tissue hypoxia be a sign of a renal cellular shutdown that finalistically aims at preserve renal function during sepsis?
Okay. It could be. That's a very philosophical question. I can't.
Exactly.
We got to prove that. But I think renal, if you were to talk about renal cellular shutdown in terms of mitochondria, I think that's a very interesting investigation. So our current work is looking at both mitochondrial structure and function, and the consequences of hypoxia in causing the mitochondria to be affected. But in terms of is the kidney doing that to preserve its health, I can't answer that question. Yeah, could be. Yeah,
could be. Okay. Another question, a more general question, probably a philosophic question. Looking at the future, do you think that the idea of a patient regional organ monitoring will be feasible soon or later?
I think the brain will be a little bit more difficult. I'm not a huge fan of NIRS. I think NIRS is good for certain things, but I think brain neuro monitoring requires a little bit more improvement. Kidneys, I think the bladder urinary oxygenation brings about a very interesting aspect of looking at renal health, at least in the medulla, in real time. But what the company need to do is really to develop a bladder catheter with an indwelling oxygen sensor. So we don't have to really, punch holes in the catheter and really, introduce airlocks and all kinds of other things. But the company that we're working with, Oxford Optronics, is moving into that space. So I think if they do successfully build a Foley catheter with a, inbuilt oxygen sensor, that could be, I think, an improvement. But again, we got to also understand the limitations of that technology as well. It is, it's sensitive to things like, extreme oliguria. So it can detect things in early stage AKI, but advanced AKI, if the urine takes too long to come from the collection ducts to the bladder, then there's ability for gas exchange between the ureter wall and the urine as well. So there are limitations to that technology, but I think we need to move towards organ monitoring if we can. I think there has to be more research done in this space, as well as the development of blood-based biomarkers. But even blood-based biomarkers, the problem is they're all batch processed at the end. So once we get a good biomarker, I think we should move towards a point of care testing developments as well. I think both in combination, hopefully, in the future. Yeah.
Okay, thank you very much. There is another question. Okay, there were, for example, in the septic shock, there were any significant differences in the amount of fluid administered, and what approach you typically use in routine management of these patients? More liberal, more restrictive, and in line with the improvement in kidney injury, if there were any difference in how diuretic therapy was managed?
Quite a few questions there. Sorry, can you repeat that just so I can gather all of it? So when you talk about the treatment, I talk about sodium ascorbate, or I wasn't sure which aspect of your.
No, in the management of septic shock. The question is, there were any difference in the amount of fluid administered?
That was the same between the groups. That was controlled.
Exactly. Yeah. What approach you typically use in routine management of this patient? More liberal or more restrictive? And
it's yeah. Sorry. Yeah, go ahead.
Okay. And in addition, in line with the improvement in kidney function, in kidney injury, there were any differences in how diuretic therapy was managed?
Okay, so I see where it's going. Okay.
Or restrictive, and yeah. If the kidney injury improves, how do you manage the diuretic therapy?
Yep. Okay, so it was more liberal. I would say Australia seems to have a little bit more. We are on the more liberal side of management, where some, some I know some continents are more dry. We are more on the liberal side. But in terms of interventions for acute kidney injury, what we did document in that first trial was that the patients in the placebo treatment required more interventions for AKI management than the patients that was receiving sodium ascorbate, but that wasn't documented very well because that wasn't something we were really looking for. But in our ongoing trials, we are also documenting that as well, where although patients are going to be, it's an adjunct therapy, but the placebo treatment might need more interventions for management of AKI as well as other multi-organ function than a drug that might be doing benefits. So that's something we have incorporated into our clinical trial design.
Okay, thank you. There are another question. Okay, moreover, the compliments for your presentation, there is a question. Using your model of sepsis, what the evidence of using norepinephrine versus vasopressin or angiotensin? Did you test extracorporeal filter, toramycin or cytosorb, and look the effect on renal medullary perfusion?
Great question, actually. So yes, we have looked at in our model comparing norepinephrine versus vasopressin and angiotensin 2. Norepinephrine makes things worse for the kidney in terms of exacerbating the renal medullary ischemia and hypoxia. Angiotensin 2 and vasopressin did not exacerbate it, but did not make it better either. So the level of ischemia and hypoxia stayed as it is. But with angiotensin 2, we can achieve improvements in renal function a little bit better because it's a preferential efferent arteriolar vasoconstrictor, which I think really goes a long way to improve the glomerular hydrostatic pressure and increasing GFR. But we've done this in early and late sepsis. So in the early sepsis work that was done, you can achieve quite big improvements in renal function. But when we did this in established septic AKI at stage 1, stage 2, AKI KDIGO criteria in the sheep, the improvements in renal function wasn't as good as the early sepsis work that was done. So angiotensin 2, I think, doesn't make things worse for the kidney in terms of the microcirculation, but the functional improvements we saw in advanced AKI wasn't as promising as what we have seen in early sepsis AKI studies. Are we doing stuff on extracorporeal filters? Great question. That work is just carrying on at the moment. And we are still, we finished the study actually, but we are currently analyzing the data to look at the effects of these extracorporeal filters on the renal macro and microcirculation as well as the brain as well. So watch this space.
Okay, thank you very much. Another question concerning cerebral perfusion and oxygenation. Did you find any difference comparing different vasopressors? Another time, norepinephrine, angiotensin, and vasopressin. In terms
Good
of
question. Oh, sorry. In terms of sepsis?
In terms of cerebral perfusion and oxygenation. Cerebral perfusion.
No, we did not. So in the sepsis model, norepinephrine, improving blood pressure alone with fluids and norepinephrine does not improve cerebral tissue oxygenation or perfusion. We did not look at other vasopressors in sepsis, but in cardiopulmonary bypass, in that study I presented, we looked at, norepinephrine, epinephrine, vasopressin, and phenylephrine. Cerebral tissue perfusion oxygenation is not affected or by bypass, and those vasopressors had no effect on cerebral perfusion oxygenation in cardiopulmonary bypass.
Okay, and there is a good compliment for your lab. The question is, are there other labs as good as yours anywhere in the world? And another question.
I'm a little biased. I'm like, no, our lab is the best in the world. No, I'm kidding. Look, everyone's doing great work. But I think the part I would like to emphasize is one of the things that is unique to our group is the fact that we can make all these measurements in the non-anesthetized animal. And I think that's a very important thing for us to understand. is if you do animal models under general anesthesia and make the brain, heart, kidney measurements under general anesthesia and say that's the normal state that we're going to return things to, and then you induce disease and you return things to general anesthesia state, all I can say is general anesthesia levels of brain, heart, and kidney measurements is not the normal state. So I think one of the strengths in our model is we can make those measurements in the non-anesthetized state, in the conscious shape, brain, heart, kidneys. And then when we induce diseases, we're not trying to return things to general anesthesia. We're trying to return things back to non-anesthetized state. I think that's a very important thing to understand. General anesthesia is not normal. And I think returning things to general anesthesia levels, I think I think should be viewed with caution. Yeah, that's all I'll say.
Okay, another question. In patient undergoing vasopressor-driven resuscitation with norepinephrine, is urine output still an adequate target of successful resuscitation and organ perfusion? And according to your data, medullary hypoxia get worsen. Should we take a look at the ability of the kidney to concentrate urine instead as a proxy for adequate perfusion of a functional medulla? Two questions.
I think that's a fantastic question. We have a running joke in our group of clinicians and scientists saying when norepinephrine is infused and urine comes out, it's not urine, it's renal tears. So I think look, we don't believe from what we have seen norepinephrine is the safest for the kidneys when there is incipient AKI. But of course we need to come up with a better alternative, right? I mean, that's what we have. I understand why we had to use it, but I don't think it's the best. Urinary output, producing urine is a good measure of renal function. I mean, that's uncoupled sometimes. It sometimes could be a pressure-induced natriuresis, and we can see that with repeated fluid bolus therapy. You can get natriuresis, but that doesn't mean function goes up. So every time the urinary output comes up, you need to look at creatinine clearance to see if creatinine clearance follows that track. With norepinephrine, initially you get this peak in creatinine clearance if you're looking at creatinine clearance, and then it kind of comes back to normal. The urinary output increases sustained, but it's really uncoupled from function there. As you can see, we've seen similar effects with diuretics like furosemide and amiloride and all these things as well. So I think you're treating urinary output as sustained functional gains is a very, again, I don't think that's, I don't agree with it from what I have seen so far. Should we look at the ability to concentrate urine? I think it's a very good question. I think that should be a good functioning medulla, and we haven't explored that, but I think that's a really insightful comment, and I think we need to investigate that further. The ability to concentrate urine. Yep.
Thank you very much for this, for your answers, for your time. I think that Professor Caironi could conclude this excellent presentation.
Yeah, thank you, Silvia, and thank you very much, Yogesh, for your really excellent and inspiring lecture. I really enjoyed it a lot. Very cool stuff, I would say. And well, first of all, thank you for your availability and time, because for you it's a nighttime session of lecture. And to me, I think it was really inspirational to show that research needs translational from experimental settings to clinical settings and back to experimental settings. You have shown that very, very many times in different topics, and I think it's really the important way and the crucial way that we need to follow. So thank you really very much. With that, I really would like to also to announce the next webinar that we will have in March 12.
Yes.
We will host Professor Fernando Zampieri, originally from Brazil, but now he's in Canada. He's another rising and leading expert especially in clinical trials on fluid therapy and other therapies in critical care medicine. The webinar will be at 4 p.m. The title has still to be defined, and we will course, keep you posted on that. I just remind you that all the recordings will be available, right, Thomas, on our YouTube channel. And I think that with that, we can conclude our webinar. And I really, once again, thank you very much to Yogesh and to all the panelists. And see you in March. Okay.
Yeah. Thank you, Yogesh. Thank you so much.
Thanks
Have
for
a nice
hosting me.
evening to everybody.
Bye.
Bye-bye.
Thank you, Yogesh. Thank you.
Thank you. Bye-bye.
Bye, everybody.